we are the only vascular clinic for 1.6 million, so that will keep us quite busy. So we do about 1,500 procedures a year, and of course these are like open arterial procedures, and of course a lot of angio and endovascular and hybrid stuff as well, but I won't go into that. And of course, as part of these, we make about 250 carotids annually. Infrainguinal bypass is about 300 almost every day, even some duty cases on Christmas Eves and so on. So there's always something going on in this field. And about 200 dialysis access as well, almost every working day. And of course, a lot of other stuff, endarterectomies, acute ischemia, and so on, where we also use this equipment from Medistim as well. And like Anders said, I've been working with Medistim TTFM for a very, very long time. I think it was in Berlin 1995 at the Congress where my boss at that time saw this machine for the first time, and he told me, Anders, go to that stand and get all your knowledge you can get from this device. We want to have it. And if I'm not remember wrong, it was the manufacturer number second that came out of your factory at that time. So we thought we were very in the edge of the development at that time, and that this has been a very interesting story. I made my thesis about impact of outflow, and of course one way to measure outflow is to look at angios, pre-op and post-op, but also of course to measure different kind of hemodynamics like flow, pressures, peripheral resistance, and so on. So this has been an interesting journey. I will take you a little bit through transit time flow measurement and nearly bypass surgery and carotids, and then also intraoperative duplex scanning, which I think is a very important tool, and I think it's even more important nowadays when really demands for imaging is coming more and more important. So I will talk about that also in this speech. So this is one of my first works with Medistim device. We looked at material of crural and pedal bypasses, 172 bypasses in all, and you can see here from this curve according to recipient artery and volume flow, and these will represent successful grafts, and these with the dashed are unsuccessful hemodynamic result, and you can see a clear difference in the volume flow in these bypasses. And also when it comes to pedal, there was a difference, but not that distinct, meaning that pedal grafts are a little bit more difficult to determine what is good or bad with flow measurements. And we'll try to look at cutoff values, use ROC curves and all this kind of stuff. And actually for crural bypass is the most powerful method of estimating the hemodynamic results, and also graft patency over 1 year period was a 90 milliliters per minute cutoff for crural grafts, and that was measured as the maximum flow capacity, I mean after an injection of papaverine into the graft. And here you can see a highly significant difference, and I will show you also what it will look like in a Kaplan-Meier curve, but this is a very big difference when you talk about distinguishing regarding different parameters. So we were quite interested and optimistic about this, but not so much has actually happened since then, and I don't know really why people haven't been investigated this scientifically so more over these years, because this was in the end of 90s. We also did another interesting work, which is, I think, from a perspective of maturation or flow characteristics, a very interesting work. And here you can see 4 curves in this Kaplan-Meier plot, where we have this group 4 with flow of over 130 milliliters per minute. That is good flows when it comes to distal bypasses. And what we was interested in this study was to see whether it was a different in the development of graft stenosis, whether you have very good flow or poor flow. And you can see when you have a very good flow, there is less graft stenosis. And of course, we can argue or theorize that this is because of shear rates or things that makes the graft enlarge and like try to get used to this kind of big flow. And this had an interesting impact really on graft stenosis. So this was also an interesting finding really. You maybe have seen this publication. It's not really a peer review journal like Journal of Vascular Surgery or Lancet or anything like that, but it's a publication. It's a German letter, and this is maybe something that you might want to refer to a lot. We have tried to estimate, or Pirkka Vikatmaa, who is the principal author, has estimated the normal value of flows in different arteries, and this is nothing that we can refer to some evidence in the literature or something. It's more like our experience over many years, what you will find in operations of these patients. So you can see the ranges are wide, but just to give people a little bit of a clue where we are dealing in as it comes to flow. But of course you can't go and tell anybody that if it's under 200 in an SMA, that's something that's going to be a disaster, or if it's under 400 you're safe. Nothing is going to happen to the patient. So in this sense it's always a little bit difficult with cutoffs when it comes to TTFM. But this is actually real flow values from real life situations in Helsinki. I looked at our database from 2001 to 15. It's of course a long period of time, and we had no follow-up data to relate this to. So this is more what kind of flow values we had, but it's a huge number of patients, and I've divided them here for you as femoral popliteal bypass is 1,200 about. Femoral crural bypass, that's the tibial anterior posterior fibular artery, and these are over 1,100, and also some pedal grafts about 300. And here you can see from these histograms what kind of flow values we found in these grafts, and these are resting flow, not after papillary. And if you try to use some kind of arbitrary cutoff that I would find maybe reasonable, then you would see which kind of flow and which proportions of patients would be like in the red zone, so to say. And in my mind, this means that if you are very low in flow, in popliteal, crural, or in pedal bypasses, you really should try to look for some problems. And of course, one thing that's important with flow measurements is that you need to take into consideration not only the recipient artery, but also what kind of runoff bed you have. For example, in a femoral popliteal graft, if you know that you have a perfect 3-vessel runoff and you're down to 100 in flow, you should be very, very concerned. But if you know you are doing a bypass to a one vessel runoff with fibular artery and you get 100, then you are quite satisfied. So this is of course something you need to take into account. And also another thing I think it's important, and I was a lot of thinking about this when I did my studies of runoff score, the Rutherford runoff score, is that it's a huge difference even if the score is the same. If you have a small lady of 50 or 40 kilograms with little muscle mass, or you have a big guy of 120 with a lot of, let's say, 15 kilograms of muscle in the leg. So it makes a huge difference when it comes to flow values, and this is also something that should be taken into account. But these are like something that happened in our clinic and gives you some kind of idea where the flows are and where you should be like concerned. This is a very new paper from Japan, actually a very interesting one, and actually these guys have been doing what I've been thinking about for 20 years. So it's good that something is happening really. And what these guys did was that they took into account, they wanted to estimate preoperatively the graft flow. And what they actually did, they considered runoff. This was the Rutherford runoff score. They modified it in some way, I think. And also the quality of the graft, like good, fair, poor, and so on. And also whether the patient had diabetes, which would make calcification in the distal small arteries, and also hemodialysis, which will actually do about the same. And then they have some kind of a correction coefficient, and they got this model or this equation for 130 grafts about, and then they tested it in a smaller part of their grafts later on. And then they define something that as optimal graft flow, which would mean optimized measured graft flow if it was this estimated by this equation minus 14.6. So if the measured graft flow was a little bit less than estimated, but not much less, then it would be like an optimal situation. And then grafts that has less than this value were considered suboptimal grafts as it came to flow. And here you can see in their material the relationship between estimated and measured graft flow, and I would say quite a good actually relationship. If it would be only all the dots at one line, it would be perfect, but of course you can see some scatters here with higher flows, and that's of course natural. And then these guys looked at different outcomes of their patients, and these are significant differences when it comes to statistics. But of course, and you can see here that this black one are grafts having some kind of a problem, and these gray ones without. And of course, you can see that these patients with suboptimal flow are on this side. Of course, that comes from the formula. But you can also see a lot of optimal grafts on both sides, or some. So this is not that's cut like a knife that you have like good or bad. You also have overlapping, and that's usually problems with these kind of hemodynamic measurements. And they try to look at different things with intermediate stenosis, for example, and here you can see also the same thing, that you have most of the grafts with some problems with lower estimated flow, lower measured flow than estimated, being on this side of the curve. And also the same thing with critical stenosis and early occlusion. They also looked then at patency rates and amputation rates, and they also had significant difference in patency rates according to if it was this OFG or SFG, but not when it came to amputation anymore. And of course, when you start talking about amputation, there is so many other factors that would influence this endpoint. So it's always difficult and needs a lot of patience to show. So this is an interesting paper, but I think it's for clinical use. This is quite complicated. You need to have some kind of computer next to you so you can calculate these estimated things, and still it doesn't take into account the size of the patients or things like that. So this is a good attempt, I think. It's a very interesting one, but quite difficult maybe to use in clinical practice. So then it comes to an interesting thing when it comes to bypass. So what would you do if the flow is poor? Of course, the first thing you look at the anesthesiologist and ask, how is the patient doing? We shouldn't be in a low output situation, of course, and a lot of noradrenaline on and so on. Then you will have problems. But you check this, that you have cardiac output and that you have good arterial pressure. That would mean in general over 100 systolic pressure. And then you can check an papaverine, and of course, before you give papaverine, you should always check with your anesthetist that you are not going to put the patient in severe shock by this injection. But if the patient is stable, you can do it. It's safe. It goes over very quickly. And of course, if you get a good response, maybe the whole problem was spasm in the distal arteries. But if that's not the case, then you will look for technical errors with some other imaging tools. Duplex scanning would be the easiest one to rule out problems, and then angiography, and we will come back to this with duplex scanning. But of course, nowadays with hybrid suites and things, we can have good quality imaging. I think the threshold to do angiography has been lower, not higher, at least in my mind, in the last 10 years. But this is quite cumbersome to do still, so if you would not have to do it, we wouldn't do it. And try to increase outflow if you can. This can be problematic, not always possible. Outflow PTA is one option, or outflow or inflow PTA is one option. Of course, then you need the hybrid suite to be, you can start moving the patient around. You might need a C-arm or something, but this is what you need angiography for. And then you can do some surgical decisions. You can make a jump graft, you extend your graft down to another vessel in hope to get more runoff, or make two distal anastomosis, like a Y graft or something like that. That can be done. In case you would use a microvascular flap, you would do it immediately, but this is something you can't decide in the operation. This needs to be decided beforehand. And of course, then if you can't do anything about the low flow situation, then you would put more medication on board, maybe a clopidogrel or some anticoagulation combined to aspirin or something like that. And of course, I think in my mind also a very important thing to know for surgeons, if you can't achieve a good graft flow, whatever you do in the first operation, you end up with 15 milliliters per minute in a crural or pedal vessel. So if that graft occludes, it's no use taking the patient to a secondary thrombectomy operation. This can cost the patient his or her life, and you have really nothing to gain. You should put all the effort in the first operation, but if you can't succeed, then you should rely on your measurements and don't go in there and put the patient at risk again. Rather do an amputation of whatever is indicated. So this is also, I think, important. So this is our protocol for distal bypass surgery. We do a lot of non-invasive measurements beforehand, MRA and duplex scanning, very little DSA nowadays, and we do venous mapping and marking. And we also mark the distal anastomosis site to see if you can find a place in the vessel where it's like compressible or pulsating, so we know, or don't have so much calcification, so we know it would be easy to make an anastomosis. And then intraoperatively we use TTFM for all our patients, almost everything we do. If it's possible, we measure TTFM. If we have some problems, we would use duplex scanning for distal and also proximal anastomosis, and also for parts of the grafts which we can easily see with the duplex scanner. We don't measure maybe so much pressures anymore because we would go more easily to angiography now. If we have suspicion of an inflow stenosis, we would measure the pressure bench, but then of course the treatment would be angio and stenting and something like that. I would say though that we quite a lot now use duplex scanning for the Medistim Miracu duplex scanner for distal anastomosis almost routinely, but not 100%, but not so much on demand anymore because it's so easy. If it's there, it's so easy to look, and then you are like know that one thing is okay or not okay. And postoperative stuff, but we don't go into that. Here you can see preoperative marking of the vein. This is, and I have marked some side branches also that I need to take just to plan my incisions, and also on which level I want to have my distal anastomosis. So this I would know beforehand when I go in. And of course, this is just to have smaller wounds and less wound complications, and maybe nicer results also. That's what the patient can see. Here's one case, very an aggressive, extensive situation where amputation on the other side, and it was occlusion of a previous graft, and the patient had a difficult ulcer, and he was still in a good condition and not so old. So we took the last thing we had in our back pocket, and that was to use an allograft, saphenous vein allografts from organ donors, which we had in the fridge, and used that. You can see we had a good, very nice run of vessel in the angiogram, and the graft quality was good, of course. No major small segments or anything, because it was a healthy from a healthy person, but of course endothelium is not good, but that's another story. And here you can see very nice flow curve with TTFM, and in this case we were happy with this because everything was like looking good. We have also been publishing our results from very long bypasses, inframalleolar, those going down below the ankle. And this was presented for the first time in ESVS meeting in Porto a few years ago. And I think we are quite happy with these results. I only show you one slide from this study, not to take too much time, but you can see that primary patency rates were down to a little bit less than 50% in 10 years, and also when correcting stenosis and some thrombectomies of the grafts, we had a 10-year result of 64%. Of course, a lot of patients died and could not be followed up for this long time, but using this normal criteria for follow-up, this was this result, and we were very happy to see this. So some kind of evidence, if you like, that our protocol not to do angio in every patient seemed to work. This is an interesting case. It was an acute ischemia where we had a lot of thrombosis in the small vessel down in the foot, and this is in a calf graft going to a calf artery, and here you can see the TTFM probe in place. And what we also did, we inserted an infusion cannula through a side branch, a tributary, which I just hooked with a purse string into this kind of system to seal it. And then I was injecting thrombolysis agents through this infusion line, and then I could follow up with TTFM how the flow was increasing. This is the flow where we started, and this is the flow where we ended. And you can see that it was tripling itself due to thrombolysis of these small arterial branches and vessels. So it was very interesting to see and follow over time the flow measurement and the developing in flow. So also in acute situation, I think flow in all is very important. You really need to see that this is working. And I think also for these acute patients, we use more and more angiography really to be sure. But still, even though you have an angiogram, I wouldn't hesitate a second to also use TTFM to really see that blood is going where I want it to go. So what about duplex scanning for distal bypasses? We're not very much out there. I don't know if you saw the latest guidelines, global guidelines for critical lymphatic ischemia. There they took quite a strong stand that you should use intraoperative imaging in these situations when you treat these patients. And they actually had a strong recommendation for either duplex scanning or angiography. And actually, the duplex scanning was a recommendation which was low level of evidence, but strong recommendation. Was based on the publication by Bandyk and Johnson, which I will show you here. I think this is a very thorough way of doing this thing. They looked at all the graft, and they did papaverine injections and so on, and they categorized their graft very nicely. And here you can see the result. These are different kinds of vein bypasses, and in arm veins you see that you have much more problems with the graft than you have in these other. And here you can see a very big difference between those grafts that had no stenosis or that was revised to good grafts, only 2.5%. And these other grafts with problems have a huge risk of 90-day failure. And this is also another publication where you get quite nice criteria for what is good or bad. For example, in infrainguinal bypass surgery, you can have over 30% lumen reduction. That's of course bad, maybe thrombus. And also here you have a lot of hemodynamic criteria, which I think is important. Also the same for carotid procedures. This is a good paper to look at to have like some kind of real or clear criteria. Here you can also see for carotids that they take the stand that if you have over 2 mm residual plaque, it's bad, or if you have a mobile dissection or things like that. This is also, I think, quite a nice paper. And what I like about the Medistim device is, of course, also that you have this intraoperative probe. That it's a high frequency probe. Of course, 50 megahertz is not that high frequency. We also have one in the ward with 22 megahertz. And of course, I was also working with a guy who was doing on temporal artery intima media thickness estimations with very high frequency transducers, and that was going up to 50. So just to give you some idea where on the scale you are. But of course, those that work on very deep in the tissue, for example, if you look at aneurysms, then you are down to 5 or 6, 7 megahertz. So in that sense, this is a kind of high frequency transducer. And it's nice when you don't need to have any plastic bags or things. And of course, it's also very nice that you have this kind of sterile equipment available both in the same time, so you don't need so much machinery into the room. But of course, the transducer is small, so it's more easy to look at small things, not big things like tissue And of course, you can't look very deep, but on the other hand, you see things that are very close to the probe. So that's of course important if you are intraoperatively. This is a case of a femoral endarterectomy and femoropopliteal bypass. And actually the thing was, it was a little bit hard to estimate where to put the distal anastomosis. And that's why I wanted to look with the, so I wouldn't, so it should be on the distal side of this stenosis here. And actually it was very easy to see with the duplex scanner. And you can see quite a low flow actually in the artery beforehand. And here is the place where I put my distal anastomosis. Some plaques in the back wall, but quite good. This is graft flow after distal anastomosis. Graft is nice looking, and here's the distal anastomosis. Some reversed flow up in the popliteal artery. Then you can see towards the end there is something small waving in the lumen, but it's not significant. And here you can see the end of the anastomosis. So it looks nice. Another case in femoropopliteopedal, sorry, going down to the forefoot, and here you can see an imaging after finalizing the distal anastomosis. This would like be the graft here, and here's the pedal artery. And this is maybe not an optimal situation to have a huge plaque here at your distal end of the anastomosis. So of course, if it would have been possible to put this anastomosis in a little bit different place, it would have been better. We also looked with color flow, and actually it isn't that bad because further down the road is more calcifications coming, so we didn't actually do anything about this. And that's also because we had quite a good flow on TTFM, 45 milliliters per minute in this situation. We thought that would be quite good. And also if we compare the flow to further down the road, it was not so bad, 100 this ratio, so we were happy with this in the end. Here's just another example of endarterectomy. You can see huge calcification in the common femoral artery before, and then looking for a patch material. Here, this is a saphenous vein. It's very, very close to the edge, so that's why it could be easily seen with this equipment. So I knew where to take it from, and this is after patching. This is the proximal extension of the patch, and it looks very good. Something very small there, doesn't matter. But then when I looked in my inflow where I had the clamp, it looks quite nasty. And also from the other view, it was a huge flap extending into the lumen, and this one we did correct actually, and it had a huge impact on the flow. Here you can see before common femoral artery 250, not so bad, but then SFA only 55, but then afterwards with papaverine we could have huge flow in both arteries. So it was a nice example of a flow limiting lesion. And the next is only to give you in the same patient that from the same time an angiogram. Now we are in this region here, and it doesn't look so bad in the angiogram. Actually, you wouldn't say that there is this kind of thing inside the lumen. When you look at the duplex scanner, you can still see there's a lot of plaques in the back wall, but this was not flow limiting, so we didn't do anything about it. But anyway, you see things much clearer sometimes with the duplex scanner than with angiography. So what would be the workflow for a distal bypass? Of course, you need to select and do duplex scanning beforehand, but once you're in operation, I think after completion of the proximal anastomosis and declamping, releasing profunda flow, if you have some worrying about calcification in common femoral artery or profunda artery, it could be a good thing to check this with ultrasound duplex scanning, that you haven't caused any problem by clamping these vessels. And of course you can measure flow to the profunda after completion the proximal anastomosis. You can't measure graft flow because that should be zero when you have a clamp and you don't have any distal anastomosis. Then after you have completed your distal anastomosis, of course the first thing you would do would be to measure the resting graft flow. And of course this is very, very low and patient has been on the table for many hours, the foot is very cold, it can be only spasm that gives you a poor flow. So in that situation, you would inject papaverine intra-arterially, some in the graft, but it's important you don't do it in the common femoral, because then you have most of your papaverine in the profunda, but somewhere in the graft, or so you will have the runoff opening down here. And usually after 1-2 minutes, you will see an increase in flow. You will find the peak maybe in 2-3 minutes, and then it will go down. After 5 to 10 minutes, you will have a steady state again, and that will be like your end rest flow, which usually is a little bit higher than the first one, a little bit depending on how much spasm you have, because also hypoxemia will make vessels dilate, so it can be either of. And of course, depending on what kind of distal anastomosis site you have, and if you have been preparing and going around your distal runoff vessel, you can make a TTFM also separately from the distal vessel to see that you have really blood flow going down into the foot. But if this is not the case, if you have working with a tourniquet and only exposed the anterior surface of the vessel, you wouldn't start preparing it or going around it to make a TTFM. Then you would compress the proximal artery and measure graft flow, so then you would see how much would go down in the foot. I think that's easier. Very seldom I put the probe on my distal runoff vessel in the crural, or not in the pedal artery, never. So this is something you have to take into consideration. And of course, you would check your distal anastomosis, and that we do nowadays quite a lot with this this device, and see that you have a technically perfect anastomosis, and also try to look at the distal artery as far as you can get to see that you don't have any critical stenosis just below your anastomosis. And especially if you use a clamp on small calcified vessel, I think this is something you really need to do. So this could be, I think, in my mind, the workflow that we use for these situations. And of course, if you do an in situ, then you can detect the side branches by measuring flow. I know Kim Holding is using this technique quite a lot in Kolding in Denmark. He's doing a lot of in situ bypasses. What about pressure measurements? I mentioned it earlier, and of course it's useful to measure pressures, especially if you are concerned about an inflow stenosis. For example, you're not sure in magnetic resonance or CT angio whether this is significant or not. And the easiest thing, of course, then is to compare the radial pressure. Of course, you think then that the radial artery is the right pressure, and usually it is. But so in practice, this is what we would do, maybe for an inflow stenosis, not so much for graft stenosis anymore, because if we have poor flow of the graft, then we wouldn't start measuring any pressures anymore, then we would go directly for imaging. So I think we measure less pressures than we used to do 10 years ago. And then I switch over to carotid surgery, and first some words about TTFM in carotids. There's not so much out there, but I think the best publications comes from New York, from Enrico Ascher, and he was looking at initial data set of 29 patients, and he had 4 patients with flow under 100 mils, and 2 of these had stroke. So that was quite striking, I think. Then he looked at the larger data set, patient set later on, and he had 13% of the patients with less than 100 milliliters per minute. And then he learned that you should wait and see whether cerebral spasm would go over, and then he was left only with 5 patients that had clear cerebral spasm, and 4 patients with persistent low flow, which he treated with anticoagulation. So not so much problem found anymore than he suspected from his initial series. And these are our findings from carotids, 1,800 patients over many years. And here you can see the distribution of flow, that most of patients will have a flow between 1 and 200 milliliters per minute. And if you then start to think about, for example, Enrico Ascher's cutoff value of 100, you can actually see that quite a small proportion of carotids will be in this range. And also something that we have been discussing a lot, and there are some papers from many years ago giving some indication of high volume flow to be a risk for hyperperfusion, meaning that you get too much blood flow into the brain, because autoregulation can be on holiday after having severe carotid disease. And in this situation, you can get too much perfusion and like swelling of the brain, or even bleedings or strokes and things like that. So if you have a very high flow, we react always by reducing patients' blood pressure after the operation for some days. And we also check with transcranial Doppler that the media flow velocity is not too high, and wait for it to come down. So these are interesting things. So actually, what would you do if the flow is poor? We wait, cerebral artery spasm can go over, and we won't reverse heparinization with protamine in this situation, never. We don't do it always either, but sometimes it's nice if you have some oozing or some bleedings to give protamine to get rid of that. But in case of low flow, we wouldn't. And of course, we would look for a technical error in the endarterectomy with duplex scanning, which is very easy to do, especially if you have this kind of biological patch, or then you can see through it very nicely with the duplex. So then you would look at your reconstruction and your clamping sites with the duplex scanner. But of course, if the preoperative CT angio shows that you should have very perfect vessels down the road, no tandem lesion in the base of the skull or something like that, so you really know that you have some kind of a discrepancy here, then we would, in very selected cases, go for angio with the idea to do aspiration thrombectomy if we would find something in the intracranial vessels. But this is very rare, I would say. We also have transcranial Doppler on all our patients, so that gives a little bit more information about the cerebral blood flow. And of course, this will alter antithrombotic medication, just like I just said, according to Enrico Ascher. And then what would you do if flow is high? And I think this is even as important. So of course, you would reduce blood flow postoperatively, and this has been our practice for many years, that we like put a limit for systolic blood pressure for the next 2-3 days. Sometimes even under 100 if this is very huge flows. So I really think that this has an impact also how you treat the patients afterwards. So what about duplex scanning? There are some publication on this matter, and very different stroke rates and also revisions rates. But I think again, our friend from New York has maybe the most best quality publication, and certainly the biggest number of patients. So I just show some things from this publication. He had 15 major defects he found by duplex scanning, and these were 7 intimal flaps, 4 floating thrombus. I mean, this is a disaster. This could cause really a big stroke, devastating stroke. 2 stenosis of internal carotid artery, and 1 small pseudoaneurysm, and also 1 retrograde dissection of the common carotid artery from the clamping site, or the site where endarterectomy ended in the proximal direction. He had no thromboembolic event in this series, and he had a very low stroke rate. So of course one can argue, is it because of duplex scanning, or is it just, or do they just have such a fantastic team? Maybe both. So it seems anyway that detection and correction of major defects will decrease the stroke rates. There's also one interesting paper a few years ago where the authors made some kind of a mathematic model for estimating flow and estimating the benefit, even taking into account the costs. And I think their final statement was that based on this model or this estimate, if you don't do imaging, you will take a few percent of the patient's probability of having a good uncomplicated CEA. So you make a few percent more risk to the patients if you don't do postoperative imaging. And this is quite a strong statement, because in carotid surgery, 1% is a big number. If you have 2 or 3, or if you have 4% stroke rate, this is a big difference, because stroke rate is in all is quite small. Here is a case of carotid endarterectomy, 76-year male. 1 month earlier, he had right endarterectomy of the right carotid artery. He had stroke before that, but now after this operation, he still had a TIA, which we thought was coming from the left internal carotid artery. And of course, then we also did an operation on this side. You wouldn't operate both. That's not wise, so that you wouldn't do if you really don't have to. And in this case, it was not so technically easy. I think also quite a lot of curves here, so they had a little bit problems with the shunt and had to keep the shunt in place manually and so on. And it was compromised vision, and they made a patch, and afterwards the flow was only 39 milliliters per minute. And this is, of course, a low value that you shouldn't accept unless you know you have huge problems already in the arteries. And this is not with a click from Medistim device. This is by an iPhone, but you can see a huge flap in the distal where the patch ended. And of course, this is something that needed to be corrected. And after correction, the patient had 110 milliliters per minute and an uneventful recovery from this operation. So a very clear, correctable finding from duplex. And I'm sure this patient would have had problems if this would have been left. This is another case, also carotid endarterectomy, about the same age, amaurosis fugax. This is kind of a visual disturbance coming from the left internal carotid artery. Here you can see the picture, stenosis in the end of the common and a lot of plaques in the internal, but otherwise the internal carotid artery quite nice. And afterwards, it was direct closure without the patch, and afterwards you could see quite a normal volume flow at quite a high pressure actually. And in this case, we also looked with the duplex scanner, and here you can see a small finding that, of course, doesn't affect hemodynamics or flows or anything, but you can even imagine from the B mode that you have a little bit of blood moving into this pocket here. And this is maybe not so nice because you should not have microembolization into the brain. So this is something I would have corrected. They didn't, and the patient has been okay as far as I know, but this is something that should have been corrected. And then another thing, here you can see a duplex scanning from the same. You can't see actually the color going into this pocket, but anyway. And this is the distal site where the patch will end, and here you can see just a small intima flap here. And this is perfectly acceptable. Nothing you should do about this. This is certainly less than 2 mils in size, so that this is okay. And also the duplex scanning with color is nice. And then just another case. I'm just getting ready with this speech, and we can have some questions and discussion. But my point is, this slide is just to tell you that you can use this equipment for almost anything, and actually that's what we are also doing. Any place where we can put a probe, we will measure actually, because we want to see that something is flowing, that we have flow to the target organ. And also in many situations where we use duplex scanning, you get some important information that will take down your complication rate. And this is a kidney tumor. Here you can see a huge tumor of the upper pole of the kidney. We work together with urologists in these cases, and you can see that the tumor is going in the renal vein into the vena cava. Here you have the vein from the left kidney, but from the right kidney you have tumor going into the vena cava. And this looks not so bad. You don't have to go very high on the vena cava, but this imaging is 3 weeks old. So how can you know that this hasn't changed? So actually, it was very easy with the duplex scanner to see that now we're a little bit higher on the vena cava, and here you can see actually the tip of the thrombus. So this is just a good example that you can use these kinds of intraoperative duplex scanning in many situations to be sure what you are doing. For example, also if you do aortic surgery, you would like to look where you put your clamp, below the renals, above the renals, in between SMA and the renals and so on. But if you have a lot of thrombus inside the artery, inside the aorta, you wouldn't like to do that, because then you would with your clamp, you would have the thrombotic material loose in the volume, in the flow in the aorta, and it would go into the arteries above the clamp, for example, SMA, causing problems with the bowel, or into the renals, causing problems with kidney function. So I also think that's a very important in our hands nowadays, and especially because when you operate aortic patients nowadays, they are usually you have to clamp above the renals, or sometimes in between the vessels there, because otherwise you would do a stent graft. So most patients we operate for aortic surgery nowadays have some problems with the clamp, proximal clamp, and then we use almost routinely nowadays, we use duplex scanning for this indication as well. And of course, access surgery is an important one. I think that's maybe quite clear that it's beneficial to look at TTFM and maybe also duplex scanning. But of course, there you also have these problems with spasm of small arteries and things that you need to take care of in order to be able to rely on the flow measurements. So I just end up with some conclusions, and of course, I think TTFM is very easy to use, and it will give accurate volume flow measurements. Of course, you need to take into consideration what's said or how you teach people to use this equipment, not to measure on very curved vessels and so on. And that's of course, and to have a probe that is fitting will, even though theoretically it shouldn't matter, in practice it will do so. So fitting probes and try to measure on a straight portion of artery or graft is easier. In graft, it's usually no problem, because you don't have this native artery curvatures and things, but in native artery it can sometimes be problematic. And of course, you need to have some kind of acoustic contact in order to have reliable flow, but it's not so much you can influence on yourself, so it's quite easy to use. And of course, in our center, it's a quality control of all open vascular procedures, more or less. So we measure a huge numbers of flows. It's like a routine. It's almost like closing the skin, but of course, sometimes it's problematic to really make decision based on these values, and this we have been discussing. But of course, if you have these clearly low flow cases, then you should look for technical errors, and then you would use imaging. And of course, the first thing easiest you would think you would do in a bypass or a carotid or a fistula would be to do duplex scanning. And I think also that duplex scanning is intraoperatively used is helpful in many other vascular procedures. For example, these we have been discussing, and of course you can also measure peak systolic velocities and look if the stenosis is meaningful or not. And it's nice to have a sterile transducer. Sometimes I would be happy to have some kind of a it's a little bit small to keep in my hand, so if I could have some kind of a bigger stick or something to hold in my hand that would hold the probe. In some situation it could be good, but for the most patients this is very nice to use. And also when it comes to B mode, it can be difficult to do the interpretation, and small lesions usually doesn't make a big difference. And of course, diagnostic accuracy for excluding anatomic technical errors is quite good when it comes to duplex. So this gives some more confidence when you end up your operations. So thank you very much for this. I hope you should enjoy my speech. Thank you very much.